Hi, Dan Palazuelos here. Another roundtable discussion looking at all things community health and community health worker programs. I'm here in Mirbalais Hospital in Haiti, right outside of Port-au-Prince, on the way to the Central Plateau. And I have the honor to be here with the highly talented staff of Zanmi Lasante, partners in Health Haiti.
Physician at Zanmi Lasante for the last
themselves.
16 years.
Good evening again.
So I'm currently
Ternier,
running the community health program. So happy to be there.
Hi everyone, I'm Kenia Vissières, the project coordinator for the AICP, a kind of project to strengthen the CHW network.
Thank you. So, with this opportunity to sit down with two of PIH's top community health physicians, we wanted to explore a couple of different issues. One is the experience of community health in Haiti, the experience with different community health cadres in the Haiti context, but then also Ralph recently visited Muso in Mali and got to see their work firsthand. And I wanted to explore a little bit what some of the similarities and contrasts were from that visit compared to your decades of experience here in the Haitian context. So to start off a little bit, why don't you guys tell me a little bit about what got you in to working with community health? A lot of physicians normally are trained in the hospital system, maybe primary care, but community health itself is something unique. What's your story?
Yeah, I mean, my story started I would say 14 years ago when we started to run HIV program and TB program, and we started very low in terms of scale up. So we found that the patient did not come to the clinic. So we thought probably there was something wrong, and we, after some evaluation, we thought that the best way to get the patient to the clinic is to go to the patient house. So we started very large to go to home visit, and we started to have patients. But there, that wasn't enough. So we started to do mobile clinic, and then that was the big launch of my community and experience.
Interesting. And so you trained in Haiti?
Yes, I've been trained in the public national school of medicine. So, and I have a background of public health, management of health. And since the last 10 years now, I'm deeply involved in community care and the support.
And then the mobile clinics and the patient-mediated visits by CHWs, did you see yourself doing that as a career when you were first starting off in your training, or was that a surprise?
I mean, at the beginning, I didn't, really believe that I would make a career in this area, because the primary goal was to find patient. I thought that was like a way to succeed, to reach some milestone. But at the end, I found that was a must, and that we should continue in that way. So now it's more than an activity. It's an engagement, commitment.
And Kenia, tell us a little bit about your experience.
For me, it was the cholera. Yeah, in Beladel.
Yeah.
So I started with this project since 2010.
Right after the earthquake.
Yeah.
And then there was the cholera epidemic.
Yeah. And after that, I I had the mobile clinic cattle project in 2013. Yeah. And so it was very easy for me to do that, and it was really the thing that I can do.
And you, did you see yourself doing community health when you first started your training?
Yeah, when I was really younger, my first model was the ASC.
Yeah.
Because in the countryside where I came from, in Nicaragua,
Yeah.
my mother used to have the service from this ASC. So it was very easy for me to have a really great contact with them and to work with them.
Wow. The ASC specifically being the Agence Santé Communautaire,
Yeah.
which has been a health promotion community health cadre.
They do vaccination, all the stuff. So.
And you yourself were basically one of their patients.
Yes, yeah.
And then now, as you went through your medical training, you held them in high regard. That's fantastic. And it's interesting. I guess that's not something you hear incredibly common, because a lot of times doctors don't come from rural areas, and when they do, they don't go back to rural areas. So that's unusual. It shouldn't be unusual, but it is.
It is.
So what do you think led you to look back to your community and say, I want to work with the Agence Santé?
Because I feel that the more you are close with the community, the more you can give them the best care. So when you are clinician, you just stay at a box and you don't have the feeling to really treat them. When you have to work with the ASCP, you really can understand what the population really needs.
Yeah.
So I think it's the best way to come back to
Wonderful.
my population.
It's fantastic. And so Ralph, you grew up in an urban area.
Yeah, definitely urban, unlikely to Kenya. I mean, my life was purely like the formal profile of a doctor, and even when I got to the post that I to the place that I spent 10 years, that was really my first time, traveling to this area of the central Haiti. But I end up, seeing people which desperate need, and you cannot say, you cannot remain like not feeling their need. So I think during those years, the first 2 years of my social services, that was key for me to see these people in need that really guide me.
Fantastic. I think, so I'm sitting here with two highly dedicated community health warriors, and there's no better people to ask, what is the community health landscape like in Haiti? Who are the players? Who are the cadres? And what's the work that they do?
Yeah, as a lot of people know, that ZIA has a strong community network made by the cadre, mainly the accompagnateurs who are currently in around 2,000. And then we used to have the Agence de Santé Communautaire, but now named Agence de Santé Communautaire Polyvalent, which is the ASCP. And then we have some other vertical cadre, but the ministry wants to have only one type of CHW, which is the ASCP.
Gotcha. And so ASC became ASCP.
Yeah.
What changed?
Maybe the vision, maybe, and I can say we were part of that vision. We were part of that change where we said actually, originally it came from a partnership with the World Bank that started to think differently an approach of community health. So, and based on multiple discussion with the ministry, with partners, with the World Bank, that those discussions end up with that new type of in the ASCP, which means a polyvalent. So that the ASCP doesn't only look at the health, but look at the well-being of the household. That was mainly the idea of ASCP, the polyvalent.
Interesting.
Yeah.
And Kenia, you discussed how the ASC was very important to you growing up, but now you work with ASCPs. What do you see in terms of implementation and the experience on the ground of people that are now in the position that you once were, receiving the benefits of the services? What do you see has changed with this new focus on well-being?
At the beginning, everyone saw the ASC as a person who give vaccine, only that.
Yeah.
Now, we try to explain them that the ASCP is a person who is attached to an institution and give more than vaccine. They do education, prevention. They can alert the system from any kind of disaster or any kind of public disease.
Yeah.
Yeah.
Sure.
Like
an epidemic, like cholera.
Cholera, like polio, any kind of disease.
Outbreak.
Yeah.
Yeah.
Outbreaks.
So it's more than a person who will give vaccine.
Right.
It's more than that.
So it's more, sounds like beyond just the technical task of vaccinating, there's this larger public health perspective. Now, there's also this zeitgeist growing, this larger idea that we need to get to universal health coverage. And polyvalence sounds like it has capacity potentially for yet more diseases, like oncologic diseases, mental health diseases, non-communicable diseases. What has been some of the experience when you are considering adding more work to this polyvalent cadre?
Yeah, I mean, mostly the ASCP are focused on the priority program of the ministry, like maternal health and other disease like infectious disease. And now, regarding your question, adding more public health disease, I mean, an issue is increasing their work task. But what I think is that we will at some point, maybe in 2 years, maybe in 4 years, we will have to put those components in their workload. So now that's gonna automatically and affect their quality. Quality of their work. So now the question is for us, for the ministry, what would be the ratio? This is the question that everybody is fighting when we have any kind discussion. What should be the perfect ratio? I don't think I have it. I don't think that anybody would have the perfect one, but we need to look at the quality. We need to look at the large coverage. So these are the components that we need to take into account when we say polyvalence. I mean, what is the quality? Which area we should cover? What are the groups that we should look at?
Yeah, and I think that's really insightful, because a lot of programs are trying to find the right balance between, as you say, the ratios, meaning number of people in the population to community health worker, but then also the number of tasks that you give them, as you described. But then the point is, if you don't find the right balance, what's going to happen to quality?
Yeah.
And so you have this often huge effort to just dump tasks on a community health worker, who then, because there's poor funding, has very high ratios. And what you essentially do is crush them, you give them an impossible job. And I once heard it described, where the community health workers that get this type of job, they pretend to work, and everyone else pretends that it's a health system. It's a lot of pretending. But yet, what can we do to fix it? Now, if you yourself could design a great polyvalent community health worker program, what would that look like in terms of ratios, tasks, supervision?
I mean,
of course, you don't have to go through all the details,
I mean,
but
5
some big
years
hits.
ago, when we started to work with the World Bank in the polyvalent pilot, we thought with the World Bank that one ASCP for 100 household would be ideal, and that's what we tried to pilot during 2 years, and I think that fully worked in terms of quality, and when I say one ASCP for 100 household, that gives you one ASCP for 500, considering that here we consider an household of five people. So definitely the more and less ideal situation would be that we have one ASCP for 500 people, and once again that leads us to the funding point. So will you be then able to fund all those in the SCP that you should have to reach that ratio? But I think definitely if we are considering those diseases like oncology, mental health, NCDs as new generation of public health issues, we need to consider that as well, that kind of ratio. Some public health expert or economists would tell you that is not cost effective. I mean, but I think we should consider that number more and less. Yeah.
Fantastic. Kenia, do you have any insights to that? If you could add an element to a community health worker program to really make it shine, in your experience, what would you add?
Maybe we have to strengthen the structure they involve in, like give them better way to go to the population, like the transport, the staff they need to go there, and a better salary, a good salary. I think so. It will help.
Yeah. And what is a good salary? It's because, you often hear people say, for years, the debate was, don't pay them because they're internally motivated. Now people realize if you're asking them to do substantive things, you have to consider buying out their time just so that they can focus on the tasks at hand. But then now you're describing a good salary. How do you judge what a good salary is? Is it a number? Is it a purchasing power? Is it something compared to the minimum wage?
Maybe I will consider the minimum wage, but there's another part we can see also. You can't ask person who need to feed their children, who need to feed their children. They have to send their children to school. You can ask them to be volunteer. Their life have a cost, so you have to cover a part of this cost. Yeah. So this is why I ask for them better salary. Yeah. Like they can have the minimum to do what they have to do every day. Yeah. So a better salary is the minimum that the system established. Yeah. I think so.
And also, I would add, when we say that we are working with the community, but the CHW are part of the community as well, and not being in a situation where you paying them well, you do affect the community. Right. You're not supporting the word that you are working with and for the community because they are part of it. And the debate now, it's not on the money really, it's the recognition of the fact that they should be or they are part of the health system. So that's the main debate in my sense, that doctors, nurses, the stakeholders of the health system should have, and which is the most difficult now, to have those people who work in a fancy facility and every day, to think that, how I'm gonna reach the community with that network. So that's the main point that we need to discuss now.
For the listeners at home, there's a couple of things to paint about the Lasante program. It's in its polyvalence. It focuses on maternal-child health, as Ralph said, but also their workflow is unique in that they have to plan on having at least 4 rally posts, what's called rally posts a month, which is where the Agent Santé goes to the community and has a sensitizing, education, and organizing efforts. That also helps to create a plan for vaccinations. And then there's also at least 10 days out of the month where they're doing home visits. Otherwise, from there, they're stationed in a local health post where they pair with a nurse to deliver care. The ratios, I've heard, has been between 1 to 1,000, but now with the question of should that be the same in urban areas, there's the question of maybe 1 to 2,000 is better where people are closer, but as we're discussing, that's still a work in progress. Let's talk a little bit about another enabling factor, supervision. What have you guys seen being the role of supervision in a good functioning community health worker program?
Yeah, normally it should be the structure is made so that we do have a good supervision activity, but the issue is still the means, because we have two two different type of supervision. We have the CHW supervisor who go and work with the basic STPs, and then you have the community health nurse who go and supervise both. So all those trip to go and see the work of each people as a cost.
Yeah.
So once again, it's about funding. Supervision, yes, but if you don't have the means, I mean, there's no use to talk about supervision.
Meaning the means being the ability to fund a good program.
Daily trip to the field from the CHW to the supervisors and the community health nurse.
Gotcha. And you mean transport support,
Yes.
motorcycle of some sort?
Tools because when you go there, you have to, umbrellas. I mean, these are deals, but at the end they can block the supervision. And some project they fail because they didn't think about those little tiny things.
Yeah, it's true, and didn't budget for them.
Yeah.
Ahead of time. So for you, it's really empowering the ability to be together regularly and reliably. Mm-hmm. That is one of the core deciding factors of whether or not a program works out well. But when they do get together, what makes for a powerful, supportive supervision encounter? What are elements that you can assure that the supervisor actually does good mentorship and support?
I mean, there are different type of supervision that strengthen that part of the program. So we do have the daily activities, the daily supervision, and we do have the monthly meeting where all the imperfection, where all the mistakes on the field can be correct by the community health nurse. So these are the main part of and they can, I would say, they can work on some aspect of the training on the field doing those kind of visits.
If they go with them to the home visits and observe.
Yeah.
And sometimes it always runs the risk of a nurse supervising a community health worker for them to be rude or to treat them like they're the low worker and the nurse is the high worker. Has that been a problem? Or if it has, what do you do to correct it? If it hasn't, how do you think how you avoided that?
I mean, this is part of any kind of hierarchy structure where one person and above can be rude to someone. But we have another level of supervisors where 3 different nurses can have a conversation with the supervisor, and that's where we can correct those kind of issues.
What's been your experience, Kenia?
In my opinion, you don't have to be rude with somebody when you want to correct him. You have to just observe and correct what is necessary. And even a doctor has to train continuously. So I think this is it has to be the same for the CHW. They have to train them to applaud them when they do it right and to correct some bad point, I can say. So that's my opinion.
That's wonderful. And do you think that nurses need special training to do a good job in supervising? Or is it better to just choose some that already are known to do it well? or maybe a combination of those two elements?
Yeah, maybe a combination. It depends on the personal ability of that nurse. You know, some nurse can be very, very, very communicative, and then they have good skill of those things. So, but I don't think that. I mean, we have been seeing a lot of issues with between the community and health nurse and CHW.
Wonderful. So it's a good time to transition from the Haiti context over to the Mali context. For those of you who don't know, Mali is an NGO. For those of you who don't know, Muso is a NGO in the Mali context. Recently has received some accolades for their impressive reduction under 5 mortality through what they call the pro-CCM approach, the community case management approach, but with a proactive element in which patients are actively sought and treated near to where they live, get sick, and now get better. We thought it would be a really great idea for a team who had developed years of experience in a challenging context such as Haiti to see a young group that was inspired by the Partners in Health experience, but then now has added some new techniques to the mix. We thought that dialogue would be a fascinating one to not only provide for the participants, but then also hear from and learn from, perhaps. That's partially the reason why we wanted to have this conversation now. So, Ralph, you took that simple trip over to Mali directly from Haiti. There's a direct flight, right?
Yeah.
Yeah.
No, I'm kidding. There are multiple connections, but at the end, it was a 2-day trip.
Wow. Bless you for taking it. And so just rough impressions and what some of your reflections on meeting the Muso team.
Actually, the Muso experience was, I would say, a must, because even in 2011, I had to go to Mali because of some security an issue. I postponed that visit. So, but I've been hearing from them since a long time, and I was I was very glad to be there for, I would say, 3 days. So I would describe it in 2 ways. What I think was very, very impressive, and what I think can be an improve. So I was impressed, first of all, of the commitment of all the CHW that I met was highly committed to the work. And I was doing the home visit that I made during the 2 days. I was amazed as well with the relation, the close relation between the CHW and the household. I mean, I just to avoid any operation, I picked one of those houses to get a home visit, and most of them were very close to the CHW, and the CHW knew very well what all the health issues of the household. And then what I found was very impressive again is the way they structured. They, especially their training. They train them, and they know they're gonna make a refresher training for them in maybe two years, and then in maybe 5 years they're gonna make a big training and again. We don't have it here. So that was kind of shocking to see how they really structured their way of training. And what I found that was very nice with the Muso project is that they have a good relationship with the ministry, which in a lot of countries it's very hard. So, and the leadership team is really committed. They really understand the system approach that PIH has. So, for me, it's the same type of social justice. And then what I found that maybe needs to be improved is that the CHW doesn't act. They mostly make prevention. They make home visit where they make counseling, but they don't give vaccine. They don't give a lot of things. If they see something, they have to only make a counseling. But I think I told them that they will need to push the ministry that they have to give more responsibility to the CHW. So one last thing I think they probably need to increase. They are one of the ministry good partners, so they have to think how to extend, because I think they are maybe the one making that kind of job there. So they have to prepare themselves to be in the front line.
Yeah.
That's what I think. But otherwise, that's a very great program that I've been hearing for the last 7 years.
Wonderful. And so just two reflections on that. One of the details and one of the big picture. So the detail is if the community health worker could be given more tasks, more responsibilities as you describe, what specifically would you give them? In addition to what they normally do.
Yeah, like us, they could be responsible for vaccination or maybe family planning, all those stuff of acting in terms of services could be good.
Yeah. And then now the big picture, for full transparency to our listeners, PIH and Muso share a lot in common. Some of our top leadership are on their board. We have spent a lot of time drinking beers and talking about good things in life and community health and global health. But in addition, it's striking to see that when Muso received its international acclaim for this dramatic reduction in under 5 mortality, there were still a lot of people saying, well, we'll see if it's cost effective. We'll see if it's scalable. We'll see, instead of saying, wow, this is incredible, this specific element, which is not, by the way, a panacea for everything, but it is critically important for probably a lot of different elements of care delivery, that this proactive approach, this going out to the household, this bridging the vulnerability gap, so to speak, how immediately people were saying, well, we're not sure. And this is an experience that Partners in Health has had when we did the same work in HIV and MDR-TB and Kaposi sarcoma in Malawi, NCDs in Mexico. That's sharing that in common. You say that Muso now is very powerful. They're highly respected. They're going to have to be out in the front lines. From your experience, having been through this now for a few decades, what advice would you give them to, charge head first into the wind?
Yeah, I would. I think I told them to continue because they are really dived in the research area. They have to keep showing that they are through an article that their work is going well, and they have to keep going with the commitment and show the ministry of their country, all the partners that model is the one.
Yeah.
So that's how I told them you have to keep going with the same model and show it through papers.
And certainly some of the publications that they have been the most rigorous and impressive in the global health delivery sphere. Well, that's wonderful. So we may or may not. We now have a wonderful opportunity to hear from our Muso colleagues via pre-recording. And I think that starts to flesh out the way that these types of collaborations can bring great new ideas and thoughts to fruition. So thank you very much to both of you for taking this opportunity on a hot and noisy and busy afternoon here in the world-famous Mirbalais Hospital. After a long day of meetings, planning mental health integration into Agent Santé program.
Yeah, thanks to you, and hope our voice will be heard from any other partners that want to follow our approach.
Any final points of advice for the good people out there practicing in community health that look up to people like you as world experts and are trying to do the best they can?
Yeah, keep thinking that one day clinical team will know that the CHW is part of a health system.
And Dr. Kenia, what else?
I have to say thank you, and hope that I will continue the hard work, but still believe that it's possible to have the strengthen the system and to do our best for the population.
Wonderful.
Yeah.
All right. Thank you so much, guys. And if you are interested in hearing more about the Zanmi Lasante team or the Muso team, you can find other related podcasts here on the CHW Central Roundtable Discussion Series. Until next time, bye-bye. Oh.